So, welcome back to the afternoon session. We have a great program ahead of us, I think. And the first will be opened by Eli Diamond from MSK. Thanks, Eli.
Thank you. I'm going to present our registry-based PRO work, and this was, a lot of this work was done by my research fellow Priya Marathe, so I'm here to present this on her behalf. So the background, of course, we know that ECD patients endure a great variety of dense symptoms, physical, psychological, and otherwise. Health-related quality of life is this more sort of abstract or broader construct where sort of the constellation of symptoms that someone has is then refracted through their values and priorities to an overall sense of well-being. We don't really know what that relationship is for ECD patients, the relationship between symptoms and this overall broader concept. Unmet needs of various dimensions has not been examined yet, nor longitudinal evolution of quality of life and whether any change in symptoms, needs, or other factors can actually be associated with change in quality of life. So the goal of this study was to look at our registry, kind of take a deep dive on some of these patient-reported outcomes, quality of life, and then the relationship between the two, and hopefully provide opportunities for intervention. So the data comes from our prospective registry-based cohort study. These are patients 18 and older with confirmed ECD. We have a mix of MSK and non-MSK patients. It's a very clinically curated database. The PROs are completed at the time of enrollment at 6 months, and then every year thereafter, assuming ability to do so in English. I'll just show some descriptive statistics about sort of the distributions and frequencies of these PROs, and then we did regression modeling to associate PROs with total quality of life and change over time. So our battery includes the brief pain inventory, the brief fatigue inventory. This is what our prior fatigue and pain paper was based on. There's a 34-item supportive care needs survey implemented across cancers and for cancer caregivers that looks at these different domains of needs. We have the ECD symptom scale that looks at these 63 different disease-related symptoms. We performed the content validation in 50 patients. And then the 3 to 5 top symptoms are selected. They're rated from 1 to 10, and so it yields a continuous variable. However, the symptoms that contribute to that continuous variable can differ between patients. The overall quality of life measure, this was actually based on a focus group we did. It was at the ECD meeting 10 years ago with the FACT-G. It's a 27-item questionnaire which measures 4 domains of quality of life, and then there's a total score. So we have data from 159 ECD patients, mostly pure ECD and some mixed. And then just to sort of highlight that there's, there remains a long period of latency to diagnosis, although I think this is kind of decreasing over time. Fairly representative cohort in terms of, mostly BRAF V600E, and then at the time of enrollment, about 60 or so % of patients are on targeted therapy, and there's been sort of an attenuation of conventional treatments over time, and then there are some people who are on no treatment at all. So this is the overall FACT-G score, and just to sort of compare to other cancer types, so the mean FACT-G at enrollment is 70, 71, and then that rises to 75. A meaningfully important clinical difference is about 4 for the FACT-G. So if you look compared to other cancers, this is notably lower. I acknowledge that the standard deviation is such that you can't make a significant claim about this, but you do get the feeling that this mean score is different, even compared to advanced cancers, AML post-transplant, not like the healthiest of cancer patients. You can't really make claims about these measures just sort of including all ages. You really have to look at age deciles. If you look at the totals, they are less pretty much across all of the deciles. So, this is a very big difference, especially for the youngest patients. And then this difference is pretty much preserved across the deciles. This is quite severe in the middle age. And then, for reasons I'm not quite sure, when you get to the oldest old, there really isn't that much of a difference. But that difference in mean quality of life overall is really, that gap exists across all age deciles except for the oldest. This sort of recapitulates what we've seen before. It's the same patient population, so that's not surprising. A very high frequency of clinically relevant pain, clinically relevant fatigue, and then a high burden of neurologic symptoms, which we've observed previously. In terms of unmet needs, these are the domains. So the highest, unmet needs for psychological and emotional domain is quite high, and then physical and daily health. And then, up to 30% or 30% of the participants have 10 or more unmet needs of these 34. And then, if you look at this same measure implemented in other cancers, you do see that this is higher than diverse other cancers as well: head and neck cancer, colon cancer, hematologic cancer. Do make a note of the very interesting difference in unmet sexual needs, which I don't have a ready explanation for, perhaps hormonal type deficiencies, but the difference is quite pronounced even when comparing to other cancers. If you look at the association between symptom burden or unmet needs and overall quality of life, these are not surprising. However, I think what's notable is the effect size is quite high. The presence, the significance is quite strong between having any clinically relevant pain, any clinically relevant fatigue, and overall burden of symptom severity. So these are very, very strongly associated with overall quality of life. And then the presence of neurologic symptoms as the most highly rated symptom is associated with poor quality of life. And then all of these unmet needs independently are associated with worse quality of life. If you look at evolution over time, so the emergence of, what this means is that the emergence of clinically relevant pain over 12 months is associated with a 6-point lowering in the overall FACT-G. So it's a very, very significant effect size. And similar for fatigue, and then also change in overall symptom severity associated with a change in quality of life, and then the emergence of met or unmet needs across these domains, all associated with a change in quality of life. And then if we do this with a multivariable regression accounting for age and brain involvement because of the neurologic issue and length of diagnosis, the effect size may change, but the associations are pretty much the same, which is that change between pain is associated with change in quality of life, overall symptom severity, and then the meeting of needs. So overall, I think you can say that if you can actually manage to alleviate clinically relevant pain, you can improve people's quality of life. If you can improve fatigue, if you can improve symptom burden, and if you can meet needs that were previously unmet, these are all opportunities for intervention. So I think a lot of this is not very surprising, but I think the degree of symptomatology, even in comparison to other significant cancers, is very notable. I think that often because the patients are so complicated and because there are so many challenges, there's a bit, I don't want to say nihilism, but there's a bit of, well, this is so hard, can we actually make their lives better? But there are several opportunities if you can improve, pick whichever it is, fatigue or pain or these even needs for education and support. I think the one thing that I'm really not able to do is to examine like what what interventions led to this, especially because, in this population, treatments are probably being tailored in order to address these things, per person. So like looking at treatment doses, that felt a bit circular, so I don't think that I can make statements about that. And this does invite intervention on any of these factors that we think may be most suitable to change. And as I mentioned, Priya is the one who did this study, and this is our team, and thank you.